right, folks, we're back. I'm your host, BKP, and this is a beautiful Labor Day weekend, September morning in downtown Blue Ridge, Georgia. This is beautiful this morning. Good morning, Dr. Tidman. Good morning, Dr.
Yeah, but you notice that the older guys are in long sleeve shirts. And I was wrapped up in a blanket and I had a coat and I left it sitting over here because people in our age group, when it's 66, 64 degrees like this, we start to get cold.
I need to check your iron levels.
My iron level's just fine. I'm just old.
Levels? Listen,
he says he's just old.
He's old. No, he needs to. You need to grind up a Buick bumper and
liver
gnaw on that a little bit. Listen, I usually end with a joke. I want to start with one today.
Okay. All right, go.
Patient comes to see the doctor, and the doctor says, "I got this." This is about the speech last night. The doctor says, "I got bad news and terrible news."
Okay.
And the patient goes, "Well, give me the bad news first." And he goes, "Well, you're going to die in 3 days." He goes, "What's worse than that?" And he goes, "Well, I've been trying to reach you for 2."
So today's the day.
Yeah.
You're leaving today.
All right, let's do something. Let's get serious.
All right, well, let's get serious for a minute. But, the other night, let's just give me 15 more seconds because this is some of the reasons I absolutely love where I live. And the other night, I'm sitting on the porch, and I won't tell you what I was doing because
you were watching hummingbirds.
Hummingbirds, okay. So I'm sitting out there on the porch and I'm reading and I'm thinking, this is the weekend I got to go get the sweatshirts out. It started that nice cool night.
Yeah.
And then in the morning, what have I been doing in the morning? I've been sneezing a little bit. Started that sneezing.
Yeah, that's right. This is our ragweed season here now.
So there you go. Now we can talk about it.
All right. No, that's true. It is. And the moles are up. So not moles, mold. We're not getting back into the moles. All right. Now we're here.
Glasses
Holy moly.
Okay, we just want to.
I was wondering, now what's the molds got to do with
mold? M-O-L-D.
Mold.
All right. We want to thank Georgia Cancer Specialist affiliated with the Northside Cancer Institute for this segment today and the blanket that they let me take off when I sat here. We got questions, but one of the things that we're going to be talking about in the second question and a little bit in the first question again is stuff that Ray's been emphasizing all the time: hazard-benefit ratios of stuff and relationships with people that you can ask questions to and trust. And then when we get to the second one, I hate to blast them 2 weeks in a row, but we're going to be blasting the nutrition industry and go on the internet and make your life wonderful by buying something, right? There's a product I saw on the internet that'll make you grow hair, Ray. You can go on there and rub it on your head. It's $69 a month with a money-back guarantee you get. Now, of course, nobody ever does it. All right, well,
it's a cream, and please don't look at your wife and say this stuff tastes terrible.
Yeah, that's another one. All right, so this is really a good question because it's wrapping up about 4 or 5 things all at once. That's stuff that we've talked about, and I felt like when I read this, I wasn't clear enough when we were talking about procedures a few issues back to say that sometimes things aren't magic and you have to pull back because you thought something was going to be magic. It wasn't. My mother is 78 years old. She has had 3 years of MGUS observation and is stable according to her oncologist. You'll remember that's a protein thing and it occurs in about 4 or 5% of people over age 60, and the proper treatment is to do nothing. In February, she fell in the yard. Now, Ray's going to love this one, okay? And she obviously went to the ER, and the chest x-ray showed a small 3-millimeter spot near her heart on the left lower lung. Guarantee you, they told her, watch it, don't do anything about it. 8 weeks ago, she was very ill with a heart attack, bronchitis, and pneumonia, and was in the hospital for a week. Now, he doesn't say if it was COVID or not. Doesn't make any difference because if she had pneumonia, she certainly had stuff in her lungs, so they took a CAT scan of her lungs. CT of her chest showed a small mass in the same spot. So now it's gotten to be up to a centimeter or two. And after she went home, a PET scan showed, quote, some uptake in the same spot. Now here is the thing. She is totally well and is not sick. So now if she hadn't fallen and gotten rib x-rayed 6 months ago or so, and she hadn't been sick with a heart attack, she wouldn't be in the office. I mean, so these two things have happened to a woman, and now they're worried about this spot. The oncologist sent the images of the PET to an invasive radiologist who said the spot in that location was too close to the heart to biopsy with a needle through the chest wall, and that an MGUS should be done. Well, we talked about this just about 3 or 4 weeks ago about how you go about finding nodules. You discussed MGUS several times recently, and Monday, the chief MGUS doctor at Big Piedmont, that means Atlanta's Piedmont, did a procedure. Now this is really important. He was unable to see the lump on MGUS and thinks that this spot might not be real, and that we should do nothing for 8 weeks and repeat the CT scan.
How big's the nodule?
Doesn't say, but we know for sure if they did a PET, it had to be bigger than 1 centimeter. Because I'll explain that in 1 second.
Resolution,
yeah. The oncologist thinks this spot might not be real. We should do nothing for 8 weeks and repeat the CT scan. What can this be? What do you think we should do? Well, I think you should do what the oncologist says. I mean, that's the easy thing. But the part of the question is, what can this be? And I'm going to explain this in a minute. But Ray and I, when we were in school, we had to read chest x-rays. So when we were in the ER at night, there weren't any radiologists around. We had to do a urinalysis and dip it ourselves and stick a finger and spin a hematocrit in a tube for the blood count, work the patient up, and then at 6 o'clock in the morning tell the chief of medicine what we thought was going on. But if we took a chest x-ray, we would tell him the next morning, say, patient had pneumonia, didn't have pneumonia, or the patient had a pleural effusion, didn't have a pleural effusion, or whatever. But when the radiologist read the x-ray, he would read it like this. He said the cardiothoracic structures are normal. That means there's no fractures. The inspiratory effort is good, and the cardiac silhouette is within normal limits in size, and that C/T, meaning cardiac thoracic ratio, is 15-40. So that means that the heart is less than a half or a third the size of the chest, which is normal. Now, he's going to talk about the lung fields. He would say the lung fields are essentially clear. Now, if there's some sort of hazy thing, he's got to cover himself so he doesn't get sued. So he will say, like, and this right here happened to be in the left upper lobe, the left lower lobe, because it's next to the heart. So there is a confluence of shadows more apparent than real that should be watched. Malignancy cannot be ruled out.
CT may be indicated.
Well, no, there weren't any CTs in those days.
That's true.
That's right. We're talking about way back when it was just chest x-rays.
Serial observation.
Yeah, okay. So this is, we're talking about 50 years ago. We were in school. But there's a confluence of shadows more apparent than real, and malignancy cannot be ruled out. It stuck that in all the x-rays.
Bill,
that
I would
had
say
anything.
you've read a few thousand of those reports.
I've read a few thousand. I read the x-rays, and then I read a few thousand reports. Okay, put that first one up there. Now, this is the age of CT scanning. So, this beautiful color picture here, and this is exactly what, isn't it pretty? Pretty color picture you got over there? So this is what they're talking about. See where the edge of the, that's the edge of the heart right there,
Yes.
that little pretty little colored spot.
Yeah, I can see
pull
that
that
when
thing
I
down.
looked at it this morning.
Okay, well, go ahead. You did your homework then.
Yeah, I looked at all the
Then
graphs.
what happened to the next one? Now, what is this one? Got it up there? That's the poor doctor
Oh,
trying to figure out, see all that stuff there? What in the world does this x-ray report mean? And so he's thinking over here, infections and inflammation and cancer and just all sorts of stuff. Okay, pull that back, pull that down. So he's making that thought, and he doesn't know. This is not the job of the primary care doc. So he sends this patient to see an oncologist. Okay, there's a lump in the chest. It's got MGUS. She's already his patient, so that's the logical choice. And they go back to the oncologist, take this x-ray report. What you got there?
an algorithm.
Is that a long algorithm?
gives you options. If you go this
Because
way,
it gives you a lot of options.
Yeah.
Gives you tons of options. But can you read that right there? That's your glasses?
no.
CT scan at 3
yeah,
months.
at 3
Okay,
months.
go over here. Pip says today CT scan at 3 to 6 months. So
3 to
every
6.
yeah.
So this way 3 months.
Well,
3 to 6.
well, it depends on which one it is. But
Right,
basically, that's a huge number of options for one spot on the lung. All right, push
Right.
that one down. All right, so now.
Bill, let me
Yeah.
stop you for a minute. This is an interesting point of medical education. CT scan is easy because look, we're going to take a look. The question is, how long do we wait?
Exactly.
Right. And so that speaks to the seniority of the person that's writing the algorithm, saying, look, if it doesn't change in 3 months, anything less than 3 months, I'm not worried. If it's still there and getting bigger after 3 months, I'm worried. Not a year. Not
Yeah,
2
it
years,
moved it over to
yeah.
another place on that algorithm.
Right.
So anyway, all of the big centers, we've got what's called the pulmonary nodule clinic. It's got a pulmonary nodule clinic, and we got one at Northside Cherokee and Northside Forsyth and all of our big hospitals, where actually every pulmonary nodule is referred to the specialty clinic. I mean, we've talked before about tumor boards where you get the radiotherapist and the surgical oncologist and the urologist and everybody together. Well, in the pulmonary nodule clinic, they've got the interested parties of infectious disease, pulmonary cancer, radiology to figure out what would we be doing. And it kind of like through that algorithm there. Put the next one up. What's it say? Risk and benefits. All right.
All right.
So this risk and benefits of surgical lung biopsy. I could be needled this way, that way. I can pull it down now. So everybody at the outset is thinking about this spot. You know, when in doubt, cut it out. That's the old surgical axiom from 50 years ago, but we don't do that anymore. It's
Right.
When in doubt, cut it out if the hazard benefit ratio of cutting it out is on the benefit side. So this next list here, and this prints out to 3, got it up there? Prints out to 3 long pages. Just take a quick look. How many different categories of things? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. There are 14 categories of 6 or 8 subunits that all, pull that down now, that can all cause a solitary pulmonary nodule. 2/3 of those or more are going to go away, or they're not particularly harmful. So now we're going to let you read a few CT scans. You ready? First CT scan put up. This is a nodule. There's the heart. It's in the left lung.
Right.
But that, you don't have to be a radiologist to say, looking at that thing right there, that's a spot that ain't supposed to be there, right? Your right hand should look like your left hand, only a mirror image, and your right eye should look like your left eye,
Right.
only a mirror image. There's no spot like that over on the opposite lung, is there?
Exactly.
So that spot and that spot are on both lungs, aren't they?
Mm-hmm.
Well, that's arteries and veins and stuff. I mean, so all these spots you see in both sides here are pretty
what
much
the arrow's pointing to
symmetrical.
Is like you have always said, left eye, right eye, left hand, right hand.
Yeah.
That is not over there.
It ain't over there.
But listen, CTs don't come with an arrow on them. I want you to know that right up.
No, yeah, that's your own error. But that one right there, you don't watch that 6 weeks or 6 days. You go stick a needle in it. All right, pull that one down.
Yeah, but let me say something on that. Pull that one back up. I don't know if it's up there. Can you get the needle to that?
Easy.
Is that too close to
Oh,
the
no,
heart?
no. That's miles from the heart. Excuse me. That's close to the heart for me and Ray. That's miles from the heart for an invasive radiologist. He can stick needles where you don't even want to think about this. Things with Latin names all around it. But that would be easy to biopsy.
Because in this, they're discussing something being too close
Too
to
close to the heart. Yeah, we'll get at that again in a
Okay,
minute.
because that looks close, but
Oh, no,
I am the
yeah.
one.
Oh, no, yeah, but there's a big old hunk of air between it and the heart.
There you go.
All right,
Okay.
and that's bigger than a centimeter. That's a centimeter and a half. Now, of course, centimeter and a half is small, but it's for a guy that does this all day, every day.
What you're seeing on that CT scan does not wait 3 months to look at.
No. Now look at this next one. Now this next one, this says partly solid. See, so there's a little tiny solid thing in the middle that actually measures less than a centimeter. And then out from it is this, that with these CT scans, they've changed what they used to, the confluence of shadows more apparent than real on an X-ray now becomes there's a vague ground glass infiltrate that could be inflammatory. Everybody who's had COVID that I do a CT scan on in the next 8 weeks to 4 or 5 months, if they're still coughing, has patchy areas of ground glass, which is the long get over COVID. Okay, you can pull that down. If you had the bad flu, if you had viral anything, the pneumonia, and you feel puny 6 weeks later, 8 weeks later, you're going to have these little ground glass things. In other words, it takes a while for the lung to heal itself. Now throw up the next one. My best friend from high school is Jack Stuckey. And Jack Stuckey lives in Plano, Texas. And 45 years ago, I took a chest x-ray of Jack Stuckey in my office in Atlanta when he had to have a physical to go to work for the Chicago Board of Trade for somebody. And you got that up there? Well, this is a CT scan of a chest x-ray with this spot, but these little white spots all around it are calcium. And that is classic for, I'm not going to make you do the whole thing, pulmonary hamartoma.
Hamartoma.
Yeah, you don't want to
pulmonary hamartoma.
You don't want to get into all the stuff about the genetics of that. But anyway, pull that down. So if you've and his showed calcium in it at that time, and we had the option of operating on it and removing it to determine what it was, or taking the odds that with calcium in it, it was benign, and that it was probably a hamartoma. Couldn't know without getting it out, because it could be something else. Could have been a TB with us. But what did we do? We took another X-ray in 3 to 6 months and didn't change. Then we took one a year later, which is 18 months after the original one, and it hadn't changed. So he stopped thinking about it. And Jack quit getting medical care. Now he's retired out in Plano, and I forgot what happened, but anyway, he went in to get a physical. They did an X-ray, and they said, you got a spot on your lung. He had forgotten about this from 50 years ago, and they were getting ready to take him in there and operate on him, and he said, wait a minute, I had something in my lung way back when. So they called my office. Now, obviously, those medical records are long gone, aren't they? But my secretary that's been with me for 40 years has all those files somewhere, and she went and pulled out his old X-ray thing out of my big old chart like that from 40 years ago, found it and read to that guy over the telephone what it was, and it's exactly the same spot, it's exactly the same size on CT as it was on chest X-ray 40 years ago. So they're leaving that one alone, okay? You understand? All right, now, this guy, the main EBUS guy at Piedmont, well, I don't know which guy that is, but I know there are 2 or 3 guys down there that are magic. I mean, they can put that...
They have good hands.
Yeah, I guess they got good hand eyes. I mean, because this ain't easy. I mean, you're putting this thing into small spots. When they say, put the next one up, because we showed this 3 or 4 weeks ago. This is the lung. That's that little probe. And I showed the picture of that little probe, and it had a tiny little needle in it, if you remember. But that's a camera with 180 degree vision, and it can be turned so that you can actually look backwards, and it's got a little spot on it. So I guarantee you what he did was he went all the way out there and he stuck it in that place and he did the ultrasound, stuck it in that place, did the ultrasound, stuck it in that place, did the ultrasound, so that he ultrasounded that whole area that's 360 degrees around the end of this next to the heart, and there wasn't a spot. And what did he say? That it was too close to the heart to do blind biopsies. Now, if he'd done that and found this lump, he just stuck a needle in it. But rather than go into a spot where on an X-ray there's something and start sticking needles, that's the hazard-benefit ratios on the hazard side. Yeah, that's down now, right? So what that tells me is, at least for ultrasonography, the nodule does not exist. For CT scan, it exists. And for PET scanning, there is some uptake there, but not much. Well, what could do that? A few lymphocytes left over from the pneumonia, which she had when was in the hospital. There's lots of things that are not real. And you go
Well,
back.
they're real, but they are benign. I mean, your PET scan, as your point is making, is that the PET scan is showing an inflammatory or reactive tissue.
Something there.
That's metabolically, something happening, which could be cancer, but it could be a resolving infection or something that's healing. So that's why you're willing to wait a bit.
Yeah, but that's that's function.
Yeah.
That's not anatomy.
Right.
So that means that PET material gets picked up there somewhere. Remember now, that's
Draw that out more, Bill.
Okay, that's a radioactive isotope hooked to glucose. They stick the glucose in your vein. Well, everything in the body uses glucose for energy, right?
Except scars don't.
Yeah, but top of your skin doesn't use much.
Hair
But
doesn't.
the heart and the liver, they measure how much is in the heart and how much is in the liver. Those are big bloody things, And then if you got a spot over here, and it picks up the same amount of material as the heart and the liver, they're not too excited about it. But if it picks up 20 times the amount that the heart and the liver does, there's something going on in that spot. Okay? So that's functional, not anatomic. Now, I use this all the time. If you go to the ER because you think you've broken your rib, and they take a chest x-ray, and they cannot, you remember this now, they cannot see a fracture. And the doctor says, I tell you, that thing acts like it's broken, but we can't see it on the x-ray. Take these pain pills, and if it's not better in a week, come back and we'll look at it again. When you go back in a week, they don't do another x-ray. They do a bone scan. And the bone scan puts an isotope in your body, which goes to bone that is actively healing or dissolving, whether it's malignant or healing. And so when they do that, that thing lights up like a flashlight. And he says you've got a broken rib, not because he can see a broken rib. There's no broken rib that can be seen anatomically on x-ray. He says it's broken because that piece of rib is now red hot with healing in a lesion that is not visible. So you have interpreted the hotness as healing because you know that's what it is. Well, that's what's going on here. This is hot, but it's not really real because the ultrasonography doesn't show it. So to stick a needle in there is the wrong thing to do. They said 8 weeks. I figure why would they have said 8 weeks instead of 12? Why'd they say 2 months instead of 3? Well, when I started going back here, that length of time between the last study and the MGUS was 4 weeks. So actually it is 3 months they waited, but it's only 2 months after the MGUS. Because I was worried about why they chose 2 months instead of 3. Follow their advice. Is that good, Ray?
That's good.
What do you think? You learn anything there? Okay. What do you think now?
I think we need to thank Georgia Cancer.
There you go. I got to pull it out of you.
Northside Hospital Cancer Institute.
All right.
That little buzzer you put under him that gives him the little shock, I think that's helpful.
I know. We got to wake him up. I mean, I'm glad you're out here where it's cold. It should have been waking you up. All right, put up the next picture.
Not cold.
Put up the next picture before we